Welcome again to Stories from the Edge of Life. We once again have a very special guest, Dr. Stephen Radwany. Welcome.
Hi,
Would you mind introducing yourself to our audience?
Stephen Radwany. I'm a retired internist and palliative care specialist, also certified in geriatric medicine. And I practiced for 32 years at Summa Health in Akron, and then 4 more years at Ohio State.
Great. And I'm Parag Bharadwaj. I'm a hospice and palliative medicine physician as well. So, Dr. Radwany, would you mind sharing with us your journey as to what pulled you into palliative care? Because you've been in the field for a while. And my assumption is that as the field is evolving, things were quite different when you started working in this field.
Well, I started practice helping to run a teaching clinic in Akron in this large teaching hospital. And so we had a clinic with about between 30 and 36 residents. Sometime, or actually grew it to about almost 60 residents, training and seeing their outpatients. So I was doing that and seeing my own patients, seeing inpatients on the teaching services, etc. Um, about 6 years in 1992, my parents died a month apart, my mother and father. And that can put you for a loop, and it hit me, and I wanted to do something meaningful out of it. And I saw how their deaths had rolled out. uh, my mother was coded in spite of never really wanting that. My father spent a month in the hospital, had no place to go to get the support he needed. So I was looking around for what can I do that would be meaningful, that would make my parents proud. They're good people. Never had much money, but always served others in different ways. And uh, so I started working as a hospice medical director, somewhat on a volunteer basis, but then they'd pay me a small per diem to do that. And I was able to work it around my other job, uh, my full-time paying job, uh, and give whatever I earned back to my employer, which was a group of physicians who were very open-minded and creative themselves, and said, hey, if you see this as the direction you want to go and take us, go for it. So I started doing that, and this was a community-based hospice, but the largest one in the community back before there were a lot of for-profits. So this is 1992. And um, then I sought certification through the American Board of Hospice and Palliative Medicine. So that was a specialty created board because we didn't have official recognition at the time. So I got certification through them twice in the 90s and early 2000s. Again, before certification through ABMS was available. And kept on deepening my involvement. I began working with them in a freestanding inpatient hospice facility. Got a lot of experience. I was basically trained by some very good hospice nurses. There were no training programs, but there were some very, very strong people I worked with. And then I sought out education wherever possible on my own, going to local meetings, and training myself and visiting programs and seeing what people were doing and how they were doing it. When I went to my first double HPM meeting, there were only a few hundred participants. I sought out a little extra training abroad when I could, because I knew there was a more robust hospice and palliative care um, um, program across Europe, and the European Association of Palliative Care, the APC, had a much larger organization at the time and a large meeting. I remember I attended my uh, first meeting of the APC in London in the mid 90s, maybe, and they had several thousand attendees and hundreds of posters and research presentations. At the time when WHPM was still getting on its feet and just beginning to grow. I also visited two programs there. I visited St. Christopher's and shadowed for a couple of days, and then also visited a program on the outskirts of London in a different area that had a day hospital as well as an inpatient service and a home program. So I did that for a while. At the same time, Sumo was growing a strong geriatric program, and a leader at the time, Kyle Allen, for that program was very visionary in how he was growing that. And so this infrastructure was building that kind of crossed boundaries within the health system. It had a home component, an inpatient component, outpatient components, nursing home components. So they were already kind of breaking down some of the barriers that one might face. So when that large community hospice I was working with decided to merge with our hospital's single crosstown competitor, I gradually needed to wind down my involvement there. And we started our own hospice program at Sumo around 1998. We grew that program and then started an inpatient palliative care service in 92. Or no, I'm sorry, 91 perhaps. So we grew that program, a nurse practitioner named Hallie Mason and myself. Visited other programs. Hallie shadowed Meg Campbell in Detroit, who was very kind. I visited Pittsburgh's program, Mount Carmel's program. Where else did I visit around that time? I visited Charles Von Gutten when he was at Northwestern, which was my alma mater for residency training, and Northwestern Evanston. But I knew the downtown venue well and visited there for a couple of days. And all these people that I visited were very kind. There was no charge for this. They just gave me of their time, and I learned a lot. And then we started growing our own palliative care service, built a unit. I started working with the academy and chaired a committee called the Palliative Medicine Review Committee. This was a committee established by the ABHPM, the American Board of Hospice and Palliative Medicine, our specialty generated certifying board, and the AAHPM, in order to, like ABHPM, which was preparing specialists to become certified once we were officially recognized, and to demonstrate how mature our specialty was. The PMRC was a committee that intended to review existing fellowship programs in the country. And at that time, there were about 30, give or take, when we started, to prepare them for ACGME accreditation, because it's a rigorous process. And when you go in it cold, never having experienced anything like it, it can be quite a challenge. So I chaired that committee, had some very fine members who really helped bring me along quite a bit. I know Russ Portnoy was a member, and Kathy Foley, Ron Schonweider, Dale Loop was the lead administrator. Dorothy Moga was an advisor. Ben Munger advised us from the field of emergency medicine because he had helped bring them along as a specialty, 15, 20 years earlier. So we had a really great group. I think I was only chair because they perceived me to be least busy among them. Certainly not. I was not the most qualified by a long shot. But we began the review process. Was very painstaking. These were all paper reviews, and we went through and reviewed about 10, 12 programs a year in that way. And without site visits, of course, we had limited funding. Did that for several years, and then Dale helped lead the applications to ABMS and ACGME to gain recognition of the field as a specialty. I think those applications were submitted about 2005. And I'm proud I signed the letter to the ACGME requesting that recognition. I still have it on my wall. But yeah, but other people did most of the work, to be honest. And we gained that recognition in 2006 from both ABMS and ACGME. So then we went about the process of they went about the process of creating a formal certifying exam and a formal accreditation process. And we wound down the work of the PMRC so that because ACGME was ramping up, they gave all of their reviews over to the Family Medicine Review Committee at the time, even though there were multiple specialties sponsoring fellowships in our field. They wanted to keep it in one place. So I participated in the group that wrote the first set of program requirements. And then we advised the Family Medicine Review Committee on that first set of reviews. Russ chaired that group, that advisory group. They needed a higher profile person to do that, but he was unable to attend that first RRC meeting, so I attended it instead, where they reviewed, I think in that first year, there were 40 or 45 applications for recognition by ACGME. So I was quite honored to participate. I think I had a positive impact because it's a long story, but I feel like I had a positive impact on that review process to help them better understand our field and how many of us were sitting outside of academic medicine trying to build these programs. So that's a long-winded story, I guess. But and then I when at home, I was building a program at Akron. We built it in senior services because my partner Kyle Allen had built all that infrastructure. So gradually we built, pretty robust hospice program, grew to an ADC of about 240. Consult services, at one time we were covering 5 different large and small hospitals. And even some home palliative care and nursing home palliative care. And we're integrating our nursing home palliative care with a very good NP, Erica Hoyles, who was coordinating with the geriatric rehab units we had around the community with our geriatricians. And we had 2 inpatient palliative care units at one time as well. We started up a fellowship, took in 3 fellows a year in Akron, Ohio, able to recruit most years. And they would train side by side with 1 or 2 geriatrics fellows. And I learned a really important lesson there, or I had learned it already, is ask for the moon up front. Don't go in asking for 1 fellow and think you're going to grow it later. Ask for the maximum number you think you can handle, given the clinical opportunities for them and the faculty. And because when you go back to ask for more later, you're much more likely to run into barriers. So strike while the iron is hot and while there's some enthusiasm and leadership, because it's harder to cut them down and also very hard to add to a program once it's established. So we had that. We also created a specialty training program in pharmacy for pain and palliative care. Pam Moore led that effort in our system. So I helped facilitate that. And they helped to facilitate a chaplaincy training program in our healthcare system. So that's, we built that program over the course of 10 to 15 years. Not 10 years, really. We got that big in 10 years, to be honest. So that's where, how I got into the field. It was a natural growth.
Yeah.
I'm grandfathered in. I stole a lot of ideas from some very kind people around the country and around the world who allowed me to visit. And we even did some international work along the way, too.
What an amazing body of work. Your personal experience that prompted you to join the field, and you made an impact locally, regionally, nationally, and internationally. So you covered most of the questions I was going to ask, but I think one of the things that caught my attention was you said, so most people will think that, if you become a doctor, that in itself is doing something meaningful. And, you said while you were practicing medicine, the experience that you've gone through with your parents, you felt like you wanted to do something meaningful, right? So so I think for the sake of the audience, just so that they understand, while medicine was advancing and has been advancing over the years, there was a big gap that you observed that, that we're falling behind when it comes to taking care of patients who are dealing with end of life issues. Is that a fair statement?
Absolutely. And early on, residency taught me that. I'll never forget during residency we had a very good oncology service at Evanston Northwestern, and going in to see a patient on the oncology unit who was lady with very advanced breast cancer, now bedbound, and I'm certain we did not know how to control her pain effectively, and I'm certain our supervising physicians did not know how to either, nor how to teach us, of course. And walking into the room and she says to us, the group of physicians to the bedside, because she's in so much pain, if my dog was in this much pain, I'd be able to put her down. And you can't even do that for me. And that kind of thing sticks with you. And then seeing these endless periods on mechanical ventilation, etc. And I even sought out training early on in medical ethics, both as a resident. I did a month of that and took the Kennedy Institute courses, became a member of American Society of Bioethics and Humanities. So I sought out that training as a means to try to resolve some of these issues in practice. And I also chaired an ethics committee at SUMA for the clinical ethics committee for 22 years. That became quite busy as well. But that was one way I was trying to process and address these issues I was encountering. And I don't mean to say I didn't find meaning in primary care medicine. I loved it. I found tremendous meaning in teaching as a general internist. I loved that work. I missed it when I got so busy in palliative that I had to give it up. And I still encounter some former primary care patients. And but I just was looking for more. And then when I wasn't familiar with hospice or palliative medicine in any way from my training, zero exposure. And when I first encountered it, I thought, oh, it's like this is what I've been looking for all along. That combination of ethics, communication, needing a strong, broad base of medical knowledge to be effective at this work, I think. And also I found I just felt so at home working in a team, so much better. That was something else that was missing from training. The geriatrics began, and then we built, geriatrics and hospice, I should say, beginning that team-based approach at the same time in the U.S. So finding that also, it's if I'd been exposed to that during my training, I would have seen and felt the fit right away. Although I'm in a way I'm happy that I was able to do primary care and hospital medicine and inpatient teaching medicine on some really busy services for 6 years before I started doing this work. And I think it made me better. And is also why I've advocated for better mid-career paths for people.
What a journey!
I'm really long-winded, aren't I?
No, but it's amazing. I think you've captured everything that I wanted to ask, and I appreciate your clarification. Yes, I didn't mean to say that you didn't like primary care, but like you said, there was something missing, right? And I think you identified a gap that you wanted to fill. So I think that's probably,
and I was worried I
yeah.
was giving that impression. But I wanted to make sure it's clear. I loved primary care and I loved general internal medicine and the broad exposure I got.
Sorry, I think you probably that brought out the leadership aspects in you, and that's probably what
Perhaps.
yeah. And it's I mean, to me, you went from there all the way to helping our field being recognized as a specialty. So thank you for all your work and effort.
One of the best things we did as a program was John Masterjohn was kind of my partner when we first started the program at SUMA. He later went on to become COO at NHPCO. We jointly did a conference in Cuba with Cuban palliative care people. And that was really eye-opening and wonderful. And I've since, after that, we developed a relationship with a program in Hungary, in Pécs, large medical school in southern Hungary. We exchanged Fulbright scholars, essentially. John went over there. We hosted Agi Sikos, a physician from there, for a year. And then I was also making trips over there for teaching and other such things. But that helped develop those relationships. And then, whenever I've traveled abroad, I've looked for ways to visit other programs. I got to visit Carlos Centeno when he was in Salamanca. That's where I first saw morphine being used topically. That was in the early 2000s. Attended several EAPC meetings. Spoke at a couple of Latin American palliative care meetings and visited programs in South America. That was really enriching. Visited a program in Japan and in Seoul, Korea, and was greatly enriched by those. But again, every time I've done this, I've brought ideas home to use in our program. That's another thing I found is very enriching.
Yeah, absolutely. And I actually, it was during one of those trips that I met you. So,
Uh,
so yeah, it's been a pleasure. It's been a pleasure to have you here, and thanks for summarizing your very vast experience in the field
mhm.
and bringing about, being a change agent. So I hope to have you back because I'm
Okay,
sure there are a lot more stories to extract out of you. And but for now, we'll wind up this interview and we'll have you back for a few more.
it's been a pleasure really talking with you, and always great to see you. All right,
Thank you very much.
bye bye.